Hello, everyone. It is my pleasure to welcome everyone to the Diabetes Sisters Life Class webinar, Candid Discussions about Diabetes and Kidney Health. My name is Anna Norton, and like I mentioned, I'm the CEO of Diabetes Sisters. I will be introducing our moderator today. We'd like to welcome Diabetes Sisters faculty and webinar leader, Susan Weiner. Susan is the owner of Susan Weiner Nutrition. She is the 2015 AADE Diabetes Educator of the Year, and she currently serves as a director on the boards of AADE, which is the American Association for Diabetes Educators. Her column, Diabetes in Real Life, is featured in Endocrine Today, and her extensive work with people living with diabetes is priceless to our community. She serves on various advisory boards, including Diabetes Sisters, is the co-author of The Complete Diabetes Organizer, Your Guide to a Less Stressful and More Manageable Diabetes Life, and Diabetes 365 Tips for Living Well. She will be facilitating today's conversation with Samantha Shanken Baker and Dr. Alan Perlman. Thank you, Susan. Take it away.
Thank you so much, Anna, and a big thank you to Diabetes Sisters and to the National Kidney Foundation for supporting today's wonderful webinar. Next slide, please. So today I'd like to introduce our fantastic panelists, Samantha Shanken Baker and Dr. Alan Perlman. Samantha lives in New York City, where her career allows her to create partnerships with luxury brands around wine and spirit events, and her personal endeavors include planning events for the Diabetes Research Institute in efforts to find a cure for type 1 diabetes. Welcome, Samantha.
Thank you. I'm happy to be here.
And of course, Dr. Alan Perlman. Dr. Perlman is a board-certified nephrologist at the Rogosin Institute and an assistant professor of medicine at the Weill Cornell Medical College, New York Presbyterian Hospital. A major focus of his practice is to assist patients in slowing or halting the progression of kidney disease caused by diabetes in order to avoid the necessity for dialysis or transplantation. Dr. Perlman is also the founder and medical director of the Renal Aid Biorepository, which is a joint collaboration of the Rogosin Institute and the Weill Cornell Medical College. In addition to managing patients with kidney disease from diabetes, his practice includes the care of patients with kidney disease caused by other disease states, as well as those who already have kidney disease that has progressed to the point of requiring dialysis or kidney transplantation. Research efforts of his practice include exploration into the causes, progression, and treatment of diabetes and inflammatory kidney disease states. Dr. Perlman, welcome.
Thank you so much for having me. I really appreciate the opportunity to participate in this webinar.
Thrilled to have you. Next slide, please. So, Dr. Perlman, let's start off by you explaining to us a little bit about what kidney disease is and its relationship to diabetes.
So, chronic kidney disease is a slowly progressive in the months to years decline in the kidney's ability to filter metabolic waste products from the blood. It's basically a generic term for a number of different conditions that can damage your kidneys and decrease their ability to do their main function, which is that of cleaning out your blood. If kidney disease progresses, waste products build up to high levels in your blood, and that's what can make you feel sick when kidney disease is at a very late and advanced stage. When bad enough, you can develop other complications like hypertension, anemia, weak bones, and a whole list of other problems.
And how does that relate specifically to someone who has diabetes?
So diabetes is the main cause of kidney disease worldwide. In the United States, it accounts for just under 50% of all patients that go on to the point at which they can no longer survive without dialysis or transplantation. Those are medical tools that are used to replace kidney function. So diabetes is the major cause of kidney failure worldwide and in the United States.
Oh, thank you so much for that explanation. And Samantha, can you please share with us, when were you diagnosed with diabetes, and when along that journey were you diagnosed with chronic kidney disease?
Sure. 30 years ago about 1989, I was in college, and I had all the symptoms of diabetes type 1, but didn't know it, never heard of diabetes, didn't know anything about it. I was in my last semester. I had 4 UTIs. I was so tired. I was drinking a lot of water and going to the bathroom a lot. And I went to one doctor, and I had all the blood work signs of diabetes. Eventually, I got home to my parents, went and saw a doctor, an endocrinologist, who called me back the next day and said, "You have type 1 diabetes. You have to come back and we have to talk to you." And what they did was teach me, they said, if you want to have your next meal, you have to learn how to give yourself a shot. And so you have to go home, give yourself a shot of insulin, and then you can have dinner. At that time, I didn't know what the difference was between being high and being low, because they all felt the same to me because I felt so terrible. Well, I didn't know anybody for maybe 10 or more years. I never met a single type 1 in that time. And I had started monitoring all of my body functions, like what's going on, just going to the doctor and endocrinologist a lot. And my kidney numbers started going down. And I developed chronic kidney disease that led to a very rare genetic disease. And because of that rare genetic disease and one of its symptoms being kidney failure with chronic kidney disease, I ended up having a kidney transplant 18 months ago. And I feel very much recovered and monitored by my doctors.
Oh, wow. Thank you so much for sharing your journey with us. And I'm sure we're going to explore a little bit more into what you went through and how you dealt with some of those lifestyle changes as we go through the webinar today. Next slide, please. Dr. Perlman, we talked about diabetes being the main cause of kidney disease. I'd love for you to explore a little bit more about high blood pressure and any other factors, such as possibly autoimmune factors, that may contribute to a diagnosis of kidney disease.
So, second to diabetes, hypertension is the second most common cause of kidney failure in the United States. But as I think most of our listeners and most people really appreciate, is that neither of these conditions usually operates on itself. So hypertension can contribute to worsening diabetes, and diabetes can contribute to worsening hypertension. And both of those, when occurring in the same patient, can accelerate the damage that either one of those states on their own would have caused relative to the kidneys. But interestingly, there are families where diabetes is very, very common, and everybody in that family will get kidney disease. And there are other families where where diabetes is very, very common, and hardly anybody in that family develops kidney disease. So the tendency to progress also has a genetic component in it, which is really the underlying tendency for a given person when experiencing either diabetes or hypertension leads to a more accelerated decline in their kidney function. And so genetics are certainly important as well. There are other factors such as obesity, tobacco use, and other underlying conditions that can also contribute and make matters worse for those patients who have diabetes or hypertension.
Thank you so much. Next slide, please. So many of the people who are listening today have diabetes, and we probably have a lot of people listening today who also care about someone who has diabetes. Dr. Perlman, can you please explain to us how diabetes specifically affects the kidneys and why it's so important to maintain a blood glucose level within an acceptable range for those people?
Sure. So all of our kidneys are comprised of several 100,000 microscopic filters that clean out your blood. These filters are composed of bundles of blood vessels, and that is the mechanism by which your blood is purified. The way diabetes damages the kidneys is that it damages these filters. And so over time, diabetes leads to microscopic scarring in each of these filters. And over time, the function of the kidneys becomes impaired. We know that even brief periods of poor sugar control can lead to decreased kidney function many years later. So the better one's sugar control is for a diabetic over a longer period of time, over the longest period of time, the more likely our patients will have a good outcome. The more likely you as a diabetic will have less kidney damage and be able to go the rest of your life without having kidney damage. Alternatively, if you have periods of time where your sugar levels are high, that promotes microscopic scarring in these blood vessels that comprise the filters of your kidneys. So any period of time where your glycemic control is poor can add to other periods of poor glycemic control, poor sugar control, and lead to more damage. One other thing that should be said along this is that the earliest sign of damage to our kidneys is when these filters become incompetent. So the responsibility of our filters in our kidneys is to keep good things in the blood and to put bad things, toxins, into the urine. One of the good things that should always remain in the blood is protein. And when the protein reaches filters that have been damaged from diabetes, it's able to leak through the filters, the microscopic filters, and be detected into the urine. So the earliest sign of diabetic kidney damage is when protein is identified in the urine.
That was such a fascinating explanation and very interesting to me, and something that we may not think about when Samantha was describing that her diabetes was undiagnosed for a period of time. That can be the beginning of some damage to the kidney and really puts out there the importance of diabetes symptom awareness, not only to physicians and healthcare providers, but to the general public. Thank you so much for that. Next slide, please. And Dr. Perlman, how often should a person with diabetes be screened then or checked for kidney disease once they are diagnosed?
So most of the recommendations for diabetics and the surveillance of their kidneys for kidney damage recommend that both blood and urine testing be done on an annual basis. Some of the guidelines suggest that doesn't need to begin until 5 years following a diagnosis of diabetes. But regardless of when, for most of our patients, it really should be done on an annual basis, at least. And if there is any evidence of damage, then the frequency of monitoring should be accelerated to every 6 or 3 months, depending on the severity of the damage that has been detected.
Right. And why is blood pressure monitoring and management so important as well? And how often should that be done for a person who has type 1 or type 2 diabetes?
So similar to the checking for protein in the urine, blood pressure should be checked at least annually. And if it's seen to be elevated, and we set the target these days between 100 and less than 140 over 90. So if the blood pressure is falling below those parameters, they can be followed again in another year. But if we see that the blood pressure is higher than that, then more frequent monitoring should be done with more frequent follow-up exams on an every 3 to 6 month basis.
Yeah, really
individualized. And in addition to checking for protein in the urine, the other parameter that we like to check is your actual kidney function, which is a measure called the eGFR, which stands for the glomerular filtration rate. The glomeruli is a medical term for those filters that I mentioned in the kidneys, and this is a measure of the efficiency at which the kidneys clean out the blood. So as kidney disease progresses, that number, which is seen as a percent, can drop down to low levels, and then follow-up needs to be done more frequently at that point. So the surveillance kidney-wise for people who have diabetes relative to their kidneys involves checking for protein in the urine, checking the GFR test, which is a blood test, and checking blood pressure.
Thank you so much for explaining those parameters. Next slide, please. About a third of the people with diabetes will get kidney disease, and Dr. Perlman spoke so well about those statistics and how we have to be very much aware of that. But the good news is that there are some steps that you can take to help prevent or slow the onset or the prevention of kidney disease. Next slide. Samantha, where did you turn for education and support of your diabetes management and your kidney health once you were diagnosed with chronic kidney disease? Did you speak with an endocrinologist, your primary care physician, a diabetes educator, a nephrologist? Well, who did you speak to when you first figured out some of this information?
Well, I was very lucky because the very first doctor I saw, I ended up seeing for 20 years. And within his office, he had a nutritionist, and a dietitian mixed together, and also a diabetes educator. And they are the people that taught me, how to give myself a shot, how to manage my insulin, how to manage my blood sugar, how it deals with the rest of my life, because it's not just about your sugar. It's like everything you eat, everything, around you, like diabetes kind of affects your whole life. So there's changes you have to make. And so I had to start advocating for my own health and making appointments and things like that with my team. And then subsequently, I saw a nephrologist, and with my transplant, a number of other doctors to measure my GFR, which went down significantly.
And
so that's about it.
Yeah, so you had a lot of support, and having the support professionally and personally can make such a big difference. I also want to point out, for a lot of people, peer support, whether it's in-person peer support or online peer support for diabetes and for chronic kidney disease, can also be a life-saving measure, because people who are going through what you're going through and really understand it can sometimes really pour in a lot of great information and a lot of support when some people may not understand exactly what you're going through. Next slide, please. Dr. Perlman, can you please talk about, there's a lot of the tests that you mentioned before, but if you can go through some of the things that we're looking at this slide, the ACR, what does that mean, the urinary albumin to creatinine ratio? That would really be helpful, I think, to some of our listeners today.
Sure. So the urinary albumin to creatinine ratio, that is the test that we use to follow the amount of protein that's in the urine. So that's a simple urine test that can be done, that's very reliable, and that allows you to see the trajectory as to whether things are getting better or whether things are getting worse relative to the amount of protein that's in your urine. It's also a very useful screening test. So if you've never been told that you have damage to your kidneys, but you want to be checked out and make sure that there isn't some early evidence of early damage to your kidneys, the urinary albumin to creatinine ratio is a very simple test that any primary care practitioner can order. You don't need to see a nephrologist or an endocrinologist for that, and that will give you a clue as to whether or not there is the beginning of damage to your kidneys. The other important factor to understand about the albumin to creatinine ratio, and specifically having protein in your urine, is that once the protein makes it out of the blood and into the urine, it's not just a sign that the filters have been damaged, but the protein, which I mentioned before, is a good thing when it's in your blood. When the protein reaches your urine, it actually starts to create more damage. So protein in the urine is both a sign of damage and it is a cause of damage. So if the protein number is high in your urine, that's one way of recognizing, whoa, there's significant damage to my filters, but it's also causing more damage. So we want that number, the albumin to creatinine ratio, which again is a way of saying how much protein is in your urine. We want that number to be as low as possible. So once therapy is begun for that, that's a useful parameter for you, for a patient to follow along to find out if their therapy is successful by lowering that number or not. The other test, the glomerular filtration rate, is a blood test, which basically tells us how functional your kidneys are, how efficient your kidneys are in filtering your blood out from toxins and chemicals that shouldn't be there. The lower the number, the less efficient, and that means that there's been more damage to the kidney filters.
And both of these tests are relatively simple.
They're very simple, and these are tests that any internist, primary care practitioner could provide for any patient with diabetes. They're common tests, they're readily available, and it's a simple matter of a blood test and a urine test.
Thank you so much. Next slide, please. And what about some medications like the ACE inhibitors or proper metformin dosing, antibiotics, the nonsteroidal anti-inflammatory medications? If those medications are prescribed, what should a person do and what should a healthcare provider consider?
So that's an excellent question. So there are certain medications that are very useful in addressing both the high blood pressure that occurs for many of our patients with diabetes and coexistent high blood pressure, that also reduce the protein in the urine. And those categories of drugs are ACE inhibitors and ARB drugs. And they're very commonly prescribed. They're used to both lower the protein in the urine and to lower blood pressure. And they have also many other potential benefits on cardiac function and other vascular benefits for our patients. So that's commonly used, and anybody who has protein in their urine should be started on one of those two categories of medications, the ACE inhibitors or ARB drugs, which stands for angiotensin receptor blocker drugs. You also asked about non-steroidal anti-inflammatory medications, and those medications are over-the-counter pain relievers such as ibuprofen or Advil. Those drugs can potentially cause kidney damage, and so those are agents that really should be avoided in anybody who has known kidney damage, whether or not it's caused by diabetes or hypertension. You also mentioned a common drug that's used for type 2 diabetes, which is metformin, and that is an important, very effective drug for controlling sugar levels, but it really shouldn't be used if your GFR test, which is that test that we mentioned is a parameter of your kidney function, which measures how functional your kidneys are. If your number dips below 30, then metformin is a drug that needs to be discontinued at that point, because metformin, when your kidney function is low, can promote an acid buildup in your bloodstream, which is something obviously that we would all want to avoid.
Yes.
But you had mentioned metformin, but there are many different drug categories that need to be monitored. The doses need to be adjusted when an individual has kidney impairment. And so it's important to review with your physicians who may forget or may not appreciate the severity of one's kidney impairment when they're dosing your medications. And a good reminder is just to say, if you know that you have some kidney damage, did you double check to make sure that's the right dose given my level of kidney function?
Yeah, dosing is as important as looking at the medications, especially over time when treatment plans or situations may change. What may have been the case a year ago may not be the case right now. It needs to be reassessed. Great point. Next slide, please. So Samantha, I want to start with you here. What are some of the things that you wish that you knew before all of these diagnoses? Is there anything that you wish that you were aware of when you had diabetes, but before you were diagnosed with chronic kidney disease?
Well, I wish somewhere in my education of my health, that people actually talked about diabetes, because as a person with type 1, I had no idea what to expect. They talk about terrible diseases, but this is also like a very prominent disease that affects so many people. So I wish that I knew a resource to go to, or the proper doctor and professionals to go to treat me. And then also all these tests that you mentioned, for a long time I didn't know what they are. And when you find out that your whole life your GFR was 23, and you should be paying attention to that, which led to my chronic kidney disease and my transplant when it hit 17, I wish I knew what to look for. And so, it's been really helpful for me to talk to my peers who I know who are diabetic, who are going, to have peers, to have people to talk to who go through the same thing, and hints on like there's gel that can increase your blood sugar. There's all kinds of things you can find at the pharmacy that help. So, hints going back and forth with a group of people, I think that really helps.
And Dr. Perlman, for some of our listeners today who want to approach their endocrinologist or their primary care physicians about being screened, is there any advice that you can give them as a physician on how to approach it or how to request a test? Sometimes people feel a little skittish about bringing it up to their providers.
Sure. I think that's a really important question. I think that, like many things in life, the better preparation one has prior to your visit with your clinician, the more you'll get out of that visit. I would make sure that you prepare your questions ahead of time, and relative to our conversation today, one of those could be, have you checked my urine in the last year to see if I have kidney damage? You don't need to necessarily know that it's a microalbumin to creatinine ratio, but you could say, have you checked my urine for protein? What is the level of my kidney function in my blood tests? Those are a couple simple questions that you can prepare ahead of time prior to the appointment. The other is that when you're asking your practitioner questions, it's really important to make sure that your questions are answered. And if they aren't answered, to ask again. And if you're not getting answers that are satisfactory by your physician, either after being persistent, then it could be that that's just not an individual who's providing you with clear answers, and maybe it might be a time to seek answers from another practitioner. But I think the main thing is to have your questions prepared ahead of time, and to make sure that they're answered during your appointment. It's a valuable time that you have with your physician, and you should be well educated after your encounter with your practitioner.
That was really well put. I actually speak to people about writing down all their questions, the same thing that you suggested. So you walk in and you're looking serious, that you really want those answers, and you come out with the answers. Absolutely. It's an important discussion.
Absolutely.
And yes. Next slide, please.
And to not be afraid to ask the same question a couple of times until you get a satisfactory answer.
100%. So when we move into prevention and treatment, in addition to exercising and maintaining a healthy weight, and of course, it should be highlighted too, if you are smoking, quit. So, and seek whatever help you need in order to do that. In addition to the medications, Dr. Perlman, that we already discussed, I think it's also important to talk about vitamin and mineral supplements that one may be taking and how that might affect someone's kidney health. And then they might not be aware, especially if they've progressed into a state of chronic kidney disease. Can you comment on that?
Well, there's a lot of herbal remedies that individuals may take, and the safety of many of these things are just not well known. But often we may forget to mention to our physicians that we're taking other over-the-counter drugs or herbal remedies because they haven't been prescribed by a practitioner. So I would alert your physician or practitioner to whatever you're taking, whether it was prescribed or whether it's something that's over the counter or as well some herbal remedy that you may have had from a health food store or some nutritional store.
Yes. And Samantha, what have you changed in your lifestyle in terms of nutrition or anything else that you needed to change? I know that you had your transplant and you're doing so well for the last 18 months. Is there anything that you had to adapt to or change in your diet?
Absolutely. One of the things you mentioned here is sodium and salt. You have to be very careful about, processed foods and all those things. But when you go to a restaurant, you don't know how much salt someone is going to put into your food. And the more salt you have, the more water you gain. So it's sort of counterintuitive to everything you're doing. So it's things like salt, like measuring carbs. Like you want to have a piece of fruit, but before you have a piece of fruit, it's a simple sugar. So you have to count your carbs with everything you do. So I think you just really, really pay attention to your diet, and when you go out, like try to see if the restaurant's like going to be a good restaurant for you. Like I often tell my friends, like I can't go to sushi. That's too salty for me. So I also think, and I just wanted to add this, that everybody works. We all have a lot of responsibilities, and that stress also, affects my blood sugar a lot. And so when I have like deadlines or things that I know that like I have to complete this thing and it's making me very nervous, my doctors even notice it. They notice my blood sugar will go high, and I'm like, I can't understand it. I didn't have any food. But so there's a lot of things out there that affect your highs and lows.
Absolutely, and everyone is different, and we know the one thing about diabetes that's predictable is that it's unpredictable. So everything that you're doing, and Dr. Perlman, did you want to add something?
Yeah, I'd like to really add to what Samantha had mentioned about salt restriction. One of the, if not the major factor in worsening protein in your urine once the protein is already there is salt in your diet. So sodium becomes a huge factor in making matters worse. And so it's very tough when you're eating out at restaurants, either socially or as a part of business, to have to remind or have to ask every waiter, to ask the chef to not add salt to your food is challenging. But it's really mandatory for people who have protein in their urine. It makes a big difference. And it's just very core to, in addition to managing your sugars, managing the salt is a big part of protecting your kidneys.
Thank you so much for that. Next slide, please, Anna. These are a few resources, and certainly not all resources, that we wanted to share with all of our attendees today. And I wanted to, I'm going to turn it back over to Anna in a moment. I wanted to give a big heartfelt thanks to Dr. Alan Perlman and to Samantha for joining us today and taking the time to really share this incredibly important, informative, and personal information with our audience. Thank you again.
Pleasure.
My pleasure.
Well, thank you. Thank you, Susan and Dr. Perlman and Samantha. This has been one of the best webinars that we have held at Diabetes Sisters. The information has been so vital to our growth and development as people with diabetes. So we're so appreciative of the time that you have shared with us today. We are out of time. We had a couple of questions throughout the webinar that were answered through the slides, so I wanted just to share that. But if you have any additional questions, please email us at info@diabetessisters.org, and we'll be sure to pass those questions on to either Susan or Samantha or Dr. Perlman, and they will reply over the next couple of days. Before we sign off for today, I really wanted to thank the National Kidney Foundation also for partnering with us today on this important topic. And I wanted to thank each of you, our listeners, for registering, participating in the webinar. Tomorrow, we will have the slides that you have seen on your screen, as well as the audio from today's session. It will be available at our website at www.diabetessisters.org. And please, I urge you all to subscribe to our monthly newsletter for more information on upcoming webinars in 2019 and beyond, and any other programs and services that we may be offering. Thank you all again for tuning in, and have a great afternoon.
Thank you.